started, we had only not more than 100 pediatric endocrinologists in the country, and the burden was huge. So there were thousands of cases of pediatric endocrinology were there, but then there were very few to cater them. So what we thought that there was a need somehow to have bridge in between them to develop special interest in pediatricians and physicians, and then they can really match and manage the overall case. Since then, there have been definite improvements which have happened, and now so many new things have happened. But this was what when I started in 2007 in that regards. So we started off and we realized that awareness was a major problem. So whenever we talk of a disorder, we know that there are three things: awareness, accessibility, and affordability. Now, everybody says it's affordability, especially when it comes to hormones. They are expensive, more difficult to get, but it's actually awareness. So we started with pediatricians' awareness. This was in 2012, and we can see many of the people who are still there. Many of the faculty is the same from that time. It's continuing from there. And then we conducted a number of programs across the country. We developed 6 modules, which are still the base of many of our courses. Till now, we have conducted 120 workshops, 15 practical pediatric endocrine courses across the country, and 5 advanced pediatric endocrine symposium. This is the 6th one that we conducted. So this was the first one in 2017, and we can see Dr. Hemchand here. So he was there right away at that point of time. Again, Dr. Hemchand talked about bone age. We discussed about this. Then there was a couple of year gap because of COVID. Since then, we have been having annual events every year. Every time we have got very good people coming from across the country. Now, after conducting so many programs, what we realize that once you conduct the program, people forget about that. Whatever you teach, they will just don't remember. And it is too much effort to go in terms of money, in terms of time, manpower, and everything. So we thought of using the power of social media to highlight that. We set up this channel, which is now one of the largest channels as far as pediatric endocrinology is concerned. And it has been viewed across the globe. It provides, there are over 400 videos and everything on pediatric endocrinology. So anything and everything, it's available there. We then thought of in terms of systematic approach in terms of pediatric endocrinology learning. So we started off with our fellowship program in 2017. And as Dr. Ravindra was saying, that we are now recognized by the National Board of Examination. And it was in fact a dream for the last 10, 15 years that we were pushing for pediatric endocrinology fellowships, which were not available from NB. And now finally the dream has come, and BJ Wadia and our center is now the 2 centers which are going to provide training in pediatric endocrinology. Now, what we realize that even physical fellowships, many people who have done training and who are in practice or doing some medical education, they are unable to really come in for 2 years because it's very difficult for them to join and leave the practice. So we started with online learning in terms of medi classes followed by books. And then we thought if you want to empower people to develop applications so that they can use, and we discussed some of the innovations just recently. Our fellowship started in 2017, and both of them are here. Dr. Neha and Dr. Chetan, they started with the first program. Dr. Riddhi and Dr. Sajali was also there in the second group. Dr. Pratik is currently in UK. Dr. Sayan and Dr. Naveen are now pursuing DM courses in PGI Chandigarh and at AIMS Delhi. Dr. Manoj was here. As we can see, Dr. Vibha has joined with us as a consultant. Dhwani is currently in Patna. So we have people across the country. And we have got Dr. Alapan and Sandeep who are still there, who are working. And Dr. Nimisha is the last one to join. So we've got 13 people who have joined. And hopefully very soon we will have the National Board Accredited Fellowship, which will start here. Our learning portal provides validated tools for evaluation, assessment, and pediatric endocrinology, including a full fellowship in pediatric endocrinology. So we launched around 3 years ago, fellowship program in pediatric endocrinology, which was a very, I would say, a tough program. It has 2-year learning. Every 2 months, there are online exams. There are continuously lectures every week. Every 6 months, there is a 5 days program in which they come, they see a lot of patients, we discuss with them, and then this program happens. So there are 4 sessions which are there. We have developed a mobile application, which in fact is the most downloaded endocrinology app, and we talked about publications there. We are developing other tools like personalized intelligent EMR, which will help guide evaluation and management of pediatric endocrine disorders. We have developed BIG, the bone age assisted interpretation of growth, which recently Dr. Vibha was just talking about how it will help assess puberty, growth, bone age, and obesity at one single click. You will be able to get all the results. We are developing a personalized expert for nutrition in which it will analyze all your meal items in terms of lot of input which we don't know about glycemic load, all the other aspects. And then it will also provide based upon the requirement, the recommended 7-day allowance. So automatic diet chart will come in for patients, which is coming up. We have already developed the Diabuddy app, which provides insulin dose guidance based upon glucose as well as carbohydrate counting, which is there inbuilt in the app. And this is being validated right away. So hopefully next time we would be launching it in a proper for a general use in that perspective. We have got number of books, basic, pediatric, and advanced. So we have tried to do a lot in this area over the last decade or so. Many of our efforts have been recognized. As I showed, Dr. Riddhi won the award for Best Bone Age Presentation at Kolkata, Dr. Sayan for Puberty Interpreter, Dr. Alapan at APES, Dr. Dhwani won the Kaichi Kida Award for the DSD Interpreter, Bone Age Assisted Interpretation for Growth, Dr. Vibha. Then also, so all of presentations have been there. There are a number of publications coming out of our tools, which have been validated and developed. So our fellowship in pediatric endocrinology, as I said, is a comprehensive one. There are over 100 modules, approximately 1,000 hours of videos that people have to watch. Pre-test, post-test, live lectures are there. There are on-site 4 visits with hands-on exposure. Assessments are done bi-monthly, 6-monthly, and an exit exam. And then there are other opportunities to collaborate in terms of research, learning, and teaching. So we have had multiple, we have now 9 on-site courses. This happens every 6 months, started from 2019. To date, we have had all these on-site courses, and we can see many of the places which are here also. So this was the last course which was done just in June 25. And all of them, I think most of them are here. And this was the extensive program in which we had 300 patients coming from growth, puberty, thyroid, electrolyte, all the disorders. And they were discussed in intensive fashion. And discussion was there. So till now, 48 people have been awarded fellowships in this program. Ongoing 72 people are doing fellowship. There are many other courses also where people are enrolled. That number goes to thousands or something. 12 nationalities have been enrolled on that. So this is a way in which we are trying to increase the number of people who are working towards pediatric endocrinology. So when a pediatric endocrinologist, they have to do is basically to diagnose the condition, to interpret a lot of reports, because then we write a lot of prescriptions, manage the conditions, and take a decision. Now, often this can be complicated because there is limited access as far as pediatric endocrinology is considered in that regards, and that results in a lot of confusion. So we have been working towards developing tools which can help in terms of technological improvement to provide point of care evaluation and management diagnostic guidance in that regard. We'll talk about some of these diagnostic tools. So we'll start off with this case, 12-year-old girl with height of 120 centimeters, weight of 15 kgs. This is a common scenario. Somebody comes to us with short stature. We know most of them are physiological. 80% are physiological and around 10% will have a pathology. The role of a clinician is to not do unnecessary workup in these 80% while not missing out on this pathological cause. That becomes important from a clinical perspective. So what we did was that we have developed, the algorithms are there, they are everywhere as to how do you interpret, you look at the growth chart, the bone age, and you will get the right diagnosis. But is it happening in clinical practice? So what we did was that we took 250 cases from our own clinic, and based upon the findings, we gave it to specific people. We gave it to a pediatric endocrinologist, a pediatrician, and a trainee to try to see how much are the errors which are happening in terms of evaluation of growth failure. And what we found was there were big problems in terms of one, pathologies were being missed. Otherwise, pathology was being overdiagnosed. So on one hand, workup was not being done, and other unnecessary workup was being done. So this was something which was quite problematic. So what we thought of that, this is the time of technology. We should start using technology. Morning, we had big sessions about technology. How can we help that we have a systematic evaluation of these disorders? So we use the automated decision tree. Now, when we talk about these things, we talk about AI, automated decision, and then we talk about assisted guidance. Now, artificial intelligence requires a large amount of data set to train it. So suppose you want to develop a tool for short stature, you would need at least 10,000 cases of short stature with all the workup. And then you know that this is the diagnosis and you feed all the data to AI, it will develop its own ways of reaching the diagnosis. That, of course, is not possible, at least at the moment. So what we decided on, we'll use a decision tree, which is the algorithms that we are talking about. They are implemented in the system. So automatically it is there. So this decision tree approach, what we did was that we build up a tool which will look into all these factors. So let's see how it works. So this is a 12-year-old girl, height is 132 centimeters, and we know this child is short. Now, if you look at the growth chart, she is short for the population, but she is not short for the family. So if you just interpret it properly, you will get the right diagnosis. This is familial short stature. But when we sent this case to many experts, we found everybody had different opinion altogether. So we need to have a rational approach, because one, you need to plot on the chart. Second, you need to look at a lot of databases to get that. So what we did was that we developed a growth interpreter, in which all you have to do is to just put the basic data, height, weight, date of birth, and you will get the interpretation based upon a number of parameters that we are looking at. So these are the scenarios which will look into these parameters, and based upon that, there are algorithms which are saying that this is familial short stature to guide the diagnosis. Then we validated this. This was published a few years ago in JPEM. And what we found was that the app had around 99% concordance rate with the clinical diagnosis. So of course, we're not saying that the app can replace it. It can provide objective assessment, and it will guide us that whether we need workup or not and go forward from there. So this is in a way giving a guidance from that perspective. Now, we thought that once we have developed this for growth, we can go beyond for other disorders. So obesity, we just discussed about obesity, in which 98% is pathological. But still unnecessary workup is physiological, but still unnecessary workup is done in our other perspective. So we developed this algorithm based upon the standard guidelines from the International Obesity as well as IAP criteria, using simple things, losing age, whether less than 5 years, more than 5 years, development, vision, dysmorphism, height, SDS, and based upon that, we developed an interpreter which just asks a very few things. It asks what is the height, what is the weight, development, and then it will give you whether it is constitutional obesity, pathological obesity. This is being under consideration in Pediatric Obesity Journal. And again, we found a high level of concordance in obesity interpreter. So obesity interpreter, let's go in this case, which is a very, very common case for pediatricians who are working up a child with obesity, and somebody find the TSH of just mild elevation 7.91, started on thyroxine. But if you really interpret the growth chart and evaluate what you know, that this child is also tall. So if you have an endocrine pattern, you have obesity and short stature. What we have put there is that we have put a BMI SDS criteria to say, and height SDS criteria to decide whether it's endocrine versus a nutritional. So this is saying you don't need to do that much workup from that regards, and this thyroid does not require any further evaluation. So using objective tools can help rational decision making in that regards. One of the cases which we discussed a lot, and Dr. Pradeep presented today, about XY DSD. Whenever we used to have a class on DSD, 15 minutes later, everybody forgot everything. And when a child comes in, we are again in a complicated situation. And that's not very important, because it is something which is an emergency requiring immediate care and gender of rearing. There are algorithms which are there. This is the algorithm which we have used in our DSD interpreter. But if you can see, this is how complicated this is. So many things cannot be expected from a pediatrician to understand. So what we did is that we developed a DSD interpreter in which you have to put in data. Like here, you put the data about sodium, potassium. It will ask only whatever investigations are required. And then it will tell you this is 3-beta HSD deficiency. So this is how the diagnosis was made, and we have developed for all aspects. So this way, we are cutting down on investigations and we are reaching the right diagnosis. And again, when we did this validation study, this is under publication in Journal of Pediatric Endocrinology and Metabolism, we found that the use of DSD interpreter could reduce discordance significantly in both experts as well as non-experts. So as far as diagnosis is concerned, this can guide in that perspective. Now we have got multiple interpreters, including puberty interpreter, hypoglycemia interpreter,
calcium interpreter, electrolyte interpreter. Now, calcium and electrolyte are very good because in electrolyte, based upon sodium, potassium, it will evaluate everything, whether it's hyponatremia, hypernatremia, hypokalemia, everything is in there in the one module, and you will be able to use that. So all of you can go and have a look in that perspective. Puberty again is a very common scenario in which there are a lot of problems which are there and there are a lot of confusions. So we also have a puberty interpreter in which it will guide whether it is a precocious, peripheral, central, rapidly progressive, slowly progressive. So a basic guidance is there for the pediatrician to assess and manage from that perspective. Similarly, for boys, we know that if the testicular volume is enlarged, this is a central precocious puberty. So it's looking into those parameters like what is the to look at in terms of the overall aspects of puberty interpreter, and that will give you the clue from that perspective. So we have got tools which are looking at in terms of evaluation of the puberty. Similarly, tools for diabetes evaluation in the terms of diabetes interpreter to classify diabetes in that perspective. Hypoglycemia. So based upon the GIR values, we had a full session on hypoglycemia in which so complicated cases were there. So whether ketone is present or not, those parameters will give us a clue. So there are tools which will guide towards nearly every aspect of pediatric endocrinology evaluation. So this will make diagnosis easy. We are not saying that we should rely blindly on these tools, use your clinical judgment, but this will help you interpret results, make it much easier from that regards. The other important scenario is to interpret. So how do you interpret the data? So this was a case whom I saw recently. This was a child who was referred to us with short stature and the bone age was reported as 14 years. Now, if you say this child's height is only 135 centimeter and bone age is 14 years, hardly anything can be done. The parents had been told that we should give growth hormone. Now, what we found when we reassessed the bone age, it was only 10.5 years. So assessment of bone age is largely having a lot of issues in terms of evaluation. So what is the problem there? Is that methods are there like GP method, Tanner Whitehouse and Bone Expert, but they are either not used widely, especially the pediatricians don't use that, the radiologists don't use that, or they are very expensive. So we have developed and published a novel way of assessing bone age using only 5 sites. It's a quick way. All you have to do is to compare 5 sites, which are basically the proximal middle finger, middle phalanx, proximal phalanx, looking into the radius, ulna and thumb. And if you compare that, you will get a validated bone age. And this tool now has been used extensively across the globe and we are getting good feedbacks from there. Our own study showed that it was as good as Tanner Whitehouse method with less amount of inter and intra-individual variations, cutting down expert time from 5 minutes to 1.4 minutes. And for non-experts, when they were using Tanner Whitehouse, they were taking 8 minutes. It was cut down to 2 minutes. So this is a way in which we can rapidly expedite that. And it was quite accurate for both experts and non-experts. But now people don't even want to do the matching and they are now talking about AI-based technology. So AI-based tools are already available, but they are available at a high cost at the moment. We are in the process of working on and Vibha is collaborating with IIT Kanpur to develop a way of AI-based assessment of bone age, which hopefully should be available soon from that perspective. The other scenario, of course, is one function where people get often confused, the pediatricians, is the interpretation of thyroid hormones. So this was the case who presented with lethargy and FT4 was 6 and TSH was 9. And this child was started on thyroxine and went into shock. So why did you think this happened? So FT4 is low, TSH should be sky high. The TSH was only 9, so this was suggestive that this is most likely a case of central and the cortisol was missed. So we have developed an interpreter which looks into this combination of FT4 and TSH. So if FT4 is low and TSH is above 20, this is primary. Less than 20, this is central. If FT4 is high, TSH is low, that is most likely going into the scenario of thyrotoxicosis. And if TSH is dissectable, this is TSH adenoma. Now, this all is there everywhere. We teach about that, but still mistakes were happening. So what we did was that we have developed an interpreter in which one place you can put data, whether it is neonate, child, pregnant adult, non-pregnant adult, you will get interpretation as to whether this is normal, central, or whatever scenario. So had we done that in this case, we would have found it. If you put the data of TSH and FT4, it would have said consider central hypothyroidism. So at least there is a warning which is coming to the person that, okay, this is not something usual. The next step would be to incorporate this right in the lab reports. As soon as the lab reports are coming in the EMR, they should get a trigger that this is likely central hypothyroidism, which we are going to consider in that regards. Thyroid nodule is also a big problem, and often we find that thyroid nodule are missed and they will develop into malignancy. There are scoring systems based on ultrasound and other measures which are available, but still they are not being used in practice. So we have developed a thyroid nodule interpreter which, based upon the TSH level, the ultrasound finding and the size, will tell you whether FNA is required or not. And once you get the FNAC, what is the interpretation? So this is something which we developed on that. So now we've talked about how to diagnose and interpret. Now, once we diagnose, the next step, of course, is to manage a particular case. And management, of course, requires a lot of things. Then we find complications if the management is not proper, particularly for DKA. This was a 4-year-old girl with DKA, received fluid and insulin outside, presented with hypokalemia, was given normal saline afterward, insulin was given, and then the child had arrhythmia and have very bad outcome. Now, we are told that diabetes is something which is rare in India, but actually we are missing a large number of cases, and this is something because the management is not being done properly. We did our own study in which we found that despite a written protocol and despite all the information available, there were large number of errors which were happening in management in our ICU, and this resulted in around 68% of preventable hypoglycemia, 42% of hypokalemia, and 66% of dehydration. There is something wrong. And if the first hour treatment is incorrect, you will have all the problems which are persisting. So what we thought, we will use the ISPAD algorithm. We developed a complicated algorithm in which we loaded. So based upon that, if you just provide basic data, like what is the sugar, what is the pH, what is the CO2, dehydration, it will give you exactly how much fluid is to be given, over how much time, how to monitor, and then follow up also every 4 to 6 hours, you put the data and it will tell you what is the further management required. So this tool is very useful for peripheries in places, suppose where there is nothing which is available easily in that regards. Other problem is how to daily manage insulin. So we have a free clinic in which we give, a lot of people have that, but the problem is that when they do not give proper sick day management, they go into DKA. And one DKA will cost them more than many years actually of their old therapy. So if we can prevent DKA, that is something which is there. So we have tools to decide about insulin bolus. This is already there for physicians for correction dose and diabetes sick day. Now, there have been artificial intelligence based systems which have been developed for deciding the dose of insulin. Hopefully, they will be available soon. So what we have developed now is that we have developed a mobile application, Diabuddy, which is going to guide in terms of the insulin dose based upon glucose, activity, and meal intake. So the biggest problem in India is carbohydrate counting. So what we have done, that we have a large database of around 8,000 Indian food items. All the child has to do is to, when they are deciding a bolus dose, is to feed what they are eating. Then they have to do is to basically tell the sugar, and they will get the right dose for bolus. This is under validation, and hopefully we will be able to come out with results soon on that. Now, all this effort has been recognized. We had multiple awards for the bone age one. This is Dr. Riddhi, Dr. Sayan for the puberty interpreter. Dr. Alapan presented diabetes interpreter recently in APES. Dr. Dhwani won the first prize for the Young Investigator Award for the DSD interpreter. The Dr. Vibha presented our big tool in the SP meeting, APES meeting, the bone age interpreters, thyroid interpreter in the Thyroid Association. There have been multiple presentations, multiple publications have already committed, and there are 3 more publications which are on the way. So hopefully we are trying to develop tools which can guide and help at every level. They are not just for, let's say, pediatricians. They're also going to help in terms of endocrinologists, often because interpreting complicated reports, you don't know the reference range. Sometimes the reference is different. That is also going to be help. And hopefully these things are going to help out in terms of management. At the end, I have to acknowledge the overall the entire team, especially our leaders, Professor PSN Menon and Professor Vardar, who have been involved. All the fellows, till now we have had around 13 fellows in the whole team, and a lot of them are here. 3 of them are here, and a lot of them are in the audience as well. They have been involved. Our tech team is there, and then we have a collaboration with IIT.
Thank you, Anurag sir, for your excellent work on mobile app. It will be really helpful for especially pediatricians and trainees. And it is very impressive to all these works and awards.
Thank you.
Thank you, sir. Any specific reason why it is web-based presentation that?
The big tool requires a lot of inputs actually, so
Yeah.
it is difficult on a mobile app. So we have made it specifically web, and this allows the PDF report to be generated.
Okay.
So it's a personalized tool. It will keep the track for the child for all the time.
Okay.
And you can actually give a printed report on that. We are also working on similar personalized nutrition also. We'll talk about that.
Yeah.
The app you can't store the data in the app. So data will only be there. You will get for that particular time, but this will keep it for a long time.
Okay, that diabetes app, when it will be available?
Diabetes
so it
app
will be very
is
useful
the
because
current study right away. It's as we talk, it's being validated. Hopefully, the result should be out in the next 3 to 6 months, and then we will make it available because that's a health app being used by a child. That needs to be a proper validation has to be done before we really bring it out.